better.
All right. I think we're good to go.
So do I just talk?
Yes, sir. And then the folks online can see you here.
Oh, okay. Go ahead and go to the next slide.
Yes, sir.
It's a honor to be here and chat with y'all about probably my primary mentor growing up as a surgeon, Dr. W. Dean Warren. As a lot of you know, I have an intense fear of public speaking, even in a small group like this. So I apologize if I don't do Dr. Warren justice. Dr. Warren, I first met in 1983, or no, that's not correct, 1978, in the operating room. I was in between my first and second year of medical school, working in the clinical research clinic, and I was part of one of his studies looking at the distal splenorenal shunt versus the total shunts of various sorts. And it's interesting that I can remember that day with great detail. I came into the research unit, and Tom Shires, who was a resident at the time, the son of G. Tom Shires II, who is of the Schwartz book fame, came down and said they were doing a shunt and wanted to know if I'd come up and watch it. So I did, and in the room where the primary surgeon was one of Dr. Warren's lieutenants, William J. Milliken. The resident across from him on the right side of the table was Craig Evans, who was a senior resident, and I believe he went to practice in Spartanburg, South Carolina. And Dr. Shires, Tom, was in the right upper quadrant holding a Diva retractor. And then it was little old me, and a sucker was thrust into my hand, and folks said,
I bet that was busy.
Yeah. Folks said, suck it all up if it's red. And as the operation progressed, the door to room 1 opened, and Dr. Warren poked his head in and cried out, "Anesthesia, call the blood bank, I'm scrubbing in." And that was the first time I had met Dr. Warren, and the first of many times that I would hear him call out that phrase. He was rarely there at the beginning of the operation, but he always came in to help dissect out the splenic vein and perform the shunt. I didn't realize at the time that Dr. Warren was the great surgical scientist that he was. Of course, I was enamored with anybody who was a surgeon, but it was only as time progressed and I continued my relationship with the portal hypertensive surgical liver group that I came to understand just truly how great he was. He was like a great football coach. He demanded or commanded a great sense of loyalty from all who worked with him. He demanded excellence in research, in clinical care of the patient. He was a master technician and had a way of making operations look remarkably easy. He was a great educator, having trained numerous fellows who went on to become chairman in their own right. But he also was a great educator to students and residents. And he was completely devoted to Grady as a part of the Emory Training Institution. And he used to say that residents came to Emory, what was known then as affiliated hospital residency program, not for Emory, but for Grady. And he firmly believed in the training that they received down there. And it wasn't just words. He would oftentimes go down to Grady once a week, and he would work with the residents, but he tended not to do the most complex cases. That was left in the capable hands of Dr. Amerson. He tended to want to do residents with the first, or surgeries with the first and second year residents, hernias and gallbladders, lumps and bumps. And I know he really enjoyed that because he told me so. He was a very great humanitarian. He was always referring to, we don't do this for ourselves. We don't do this for the profession of surgery. We do it for the people. And one of his American surgical addresses when he was president actually had that title, not for the profession, but for the people. And even though he had the distal splenorenal shunt named after him, it wasn't his doing. It was what other people said about it, calling it the Warren shunt. And in fact, he did not want you to ever say that in front of him, because he realized that, like a lot of things in medicine and surgery, it was all a collaborative effort between himself and his colleagues, starting out in Miami and then progressing to Emory when he became chairman there in 1971. He was also a humanitarian in the sense that he laid the groundwork for Emory as a global surgery institute. And he did that not in a formal sense. When I interviewed with him to become a young attending, I told him that I wanted to be able to spend time in Pakistan doing surgery there at least once a year. And he wrote that into my contract that I would be allowed to do that, and I would not be docked vacation time or salary time to take several weeks to go over to Pakistan. And I did that pretty much every year until 9/11. He also did it through a former trauma fellow by the name of Priscilla Strom, who, after she finished her trauma fellowship and spent some time down at Grady, she went to Bangladesh and practiced missionary surgery there. He also worked with some of the other institutions like Vanderbilt and Harvard to work through their programs that they had instituted in Haiti. So he was a great humanitarian, and he also trained lots of fellows who were not only from America, but from foreign places as well, and then send those folks back to their own countries to teach and do research there. He was a tremendously passionate, passionate to say the least, but compassionate man. And he always talked about trying to understand the patient and how their disease, in this case, most instances, cirrhosis, was affecting them and their family. And
Mort, get out of there.
and how he
Can everyone online mute?
So he made rounds at 4 o'clock on afternoon, in the afternoon, usually by himself. And oftentimes we would come by and find him sitting on the edge of the bed with the patient, post-operatively most often. And he would be chatting to them about their lives and their families, their jobs. But he also always liked to talk about Florida football and Georgia football. And he would reminisce about the novels he enjoyed reading, particularly Westerns by a serial author known as Louis L'Amour. And he loved country music, but his favorite composer was actually the American composer Aaron Copland, who everybody would recognize the theme from 2001, A Space Odyssey, about Zarathustra. He, again, engendered a great sense of loyalty, and kind of like my tennis coach, you found yourself wanting to win the battle against disease, not so much for yourself and your personal glory or even the patient. You wanted to do it for him, and you never wanted him to be disappointed. He always took his time with me. He realized that I was not the sharpest knife in the drawer, and was very complimentary when it needed to be, but also stern when I wasn't doing things according to his desires. So in a personal sense, while I've had other mentors, William J. Milliken, J. Michael Henderson, and Dr. Amerson, Dr. Salam, Dr. Smith, Dr. Warren was primarily a formative person in my career. And so it's, again, with great honor that I talk a little bit about variceal bleeding at this point, since that's what he made his most notable contributions. He, along with others, noted 4 original observations regarding treatment of variceal bleeding. He noted that portacable shunts, while excellent in bleeding control, were associated with increased risk of encephalopathy and liver failure, and an unacceptable ultimate morbidity and mortality. He noted the devascularization procedure, which tended to be performed in other countries, had a low encephalopathy rate, but had a much higher bleeding rate post-surgical. He was intensely interested in the hemodynamics of shunt surgery, and it was recognized that in order to maintain liver function, it was critical to maintaining portal hypertension within the splanchnic circulation, as well as prograde portal perfusion. And then finally, leading up to his sentinel paper on the distal splenorenal shunt, he has observed that the splenic vein could serve as an outflow tract for decompression of gastroesophageal junction varices. The physiological rationale of selective variceal decompression is well understood. You decrease the portal pressures within the varices, while at the same time maintaining high intestinal venous pressures and maintenance of the portal perfusion. And this is not the first paper on the splenorenal, or this is the first paper on the splenorenal shunt by Dr. Warren and Zepra and Foman from the University of Miami, where they were able to report that the distal splenorenal shunt could be done technically and did decrease bleeding rate from the natural history of varices. So Dr. Warren came to Emory in 1971, and He passed away in 1989, but for another year, 10 years after that, the distal splenorenal shunt remained under intense scrutiny. Dr. Warren always emphasized randomized controlled trials. And these trials were focused on patients that had already bled from varices, but had stopped. We knew that if a patient bled from varices and then stopped, that there was a 70% chance that they would rebleed. And so during the next few decades, he focused in on the splenorenal shunt as a therapy for definitive control of variceal bleeding. And he looked at the splenorenal shunt versus total shunts, splenorenal shunt versus endoscopic variceal ablation. Back then, the study focused on sclerotherapy, but was extended to variceal banding. Following that, we started the liver transplant program in 1987 under Dr. Milliken and Henderson. By that time, Dr. Warren's health precluded him from being actively involved, but he was very supportive. And so during that time, the role of distal splenorenal shunt for variceal bleeding in the era of transplantation was examined. And then later, when TIPS became available, his partners, Dr. Henderson and Milliken, examined the role of distal splenorenal shunt versus the TIPS. So the phases of management and variceal bleeding are well known. There are treatments for prophylaxis against the first bleed, treatment of acute bleeding involving resuscitation, variceal sclerotherapy, the zinc stocking Blakemore tube, variceal embolization, and supportive care are all involved in the first time variceal bleeding. But as I said, I'd like to focus on definitive bleed therapy. From the study that looked at variceal ablation versus the distal splenorenal shunt, it became the final conclusion that with the combination of beta blockade, endoscopic variceal ablation, and that was truly serial ablation until the patient no longer had varices, that the rebleed rate could be decreased from 70% to 30%. And Emory also noted that if the patient failed non-surgical treatment with variceal ablation, that surgical rescue with the distal splenorenal shunt was appropriate. And Dr. Warren was always tremendously suspect of bias in randomized controlled trials. So he insisted that patients that underwent distal splenorenal shunt in patients who failed banding, that those patients would be analyzed in the banding group and not in the DSR group. One of his fellows who became chairman at Omaha noted from his own trial that, again, variceal banding and distal splenorenal shunt was very appropriate, but he noted that in Omaha, Nebraska, that there was a problem in access to tertiary care where banding or the shunt could be performed. So they always took in geography of where the patient lived, and if the patient lived far away from Omaha and in a location where access to Omaha care was not feasible, then they always did the shunt as a more definitive control because it had greater than a 95% control rate. So from that study, second line therapy for prevention was either decompression with shunts, tips, or transplant. And ultimately, with a combination of these therapies, 90% bleeding control was obtained. So it really fell back on what patients do you shunt, what patients do you do liver transplant, and what patients do you do tips. And back then, the mantra was if the hepatic function was poor, then you did tips as a bridge to transplantation. And if hepatic function was good, then you did a shunt. And that led ultimately to the distal splenorenal versus tips trial that I'll talk briefly about in a minute. You can go to the next slide. So again, focusing on the distal splenorenal shunt, it has excellent bleeding control rate that exceeds 85%. But ultimately, as the shunt matured and enlarged and pressures further decreased in the variceal bed, bleeding control was up to 97%, with the 3% that rebled either occurred due to shunt malfunction or the development of ectopic collateral varices across the stomach. The distal splenorenal shunt had a very low encephalopathy rate because portal perfusion was maintained, being in the 10%, 15% range, as opposed to 50% with total shunts. But Dr. Warren did realize that it was a technically demanding operation and relatively unavailable except in certain centers. He noted that the surgical stress and morbidity was high, and that ultimately the alcoholic population, either due to continued drinking or progressive liver disease, had a 5-year survival rate of only 45%. Non-alcoholic population, however, did better with survival rates close to 80% and an overall survival rate between the two groups of 50 to 60%.
John, can I interrupt and ask you a question?
Sure.
So I remember that era pretty well. The first paper that was written from Emory detailed, I think, 12 or 13 patients. And as I remember, they said they had no rebleeding in that group. Is that true?
That's what I remember too. It's interesting about his first paper that he published, and Dr. Salam may be able to comment on this, that the outcomes were exceptionally good. But then several months later, when he went to present the paper at one of the, I think it was the Southern, he had done several more shunts, and plus several of the patients from the original 12 had not done so well. And he insisted on updating the presentation to include those patients that had not done well, even though it would have meant more difficulty in accepting the splenorenal shunt as a viable option for the treatment. But he always demanded honesty and integrity in his research. So the steps of the distal splenorenal shunt we'll go over a little bit. It's it's technically a very difficult operation, even in experienced hands, but it was a fun operation, and it was made fun a lot by Dr. Warren, who had all these little sayings and witticisms and comments that were associated with each of the steps of the procedure. And in this picture, you see that the greater curve of the stomach has been taken down by division of the gastrocolic ligament. And Dr. Warren used to say that taking down or mobilizing the greater curvature was like navigating the St. Mary's River, because you crisscross back and forth across the gastroepiploic vessels up to the short gastrics from the pylorus in order to ensure adequate devascularization. And if you know from your geography, the St. Mary's River, which forms part of the border between Georgia and Florida, is considered the crookedest river in the world, because in order to go 1 mile as the crow flies, the river has so many turns and bends and so forth that it takes almost 15 miles of actual river to progress that 1 mile. So he liked to call that the navigating the St. Mary's. And then if you look over to the left next to the spleen, you see there's a band of tissue forming the splenocolic ligament. And we always took that down because there were potential splenocolic collaterals in that area, that it could actually steal blood from the shunt and decrease its selectivity. Dr. Warren, in some cases, noted, particularly in obese patients, that this splenocolic ligament was tremendously enlarged and fatty and draped over the entire left upper quadrant, making it difficult to mobilize. And Dr. Warren always talked about attacking the great glob of the great glob that ate New York. I don't know what he had against New York, but he always called it the great glob. As time went on, that great glob metamorphosized into the great fold of Zubowitz. Now, Zubowitz is a plastic surgeon of some renown. And during his time as a second year resident on the service, I am told that Dr. Zubowitz, through use of the Deaver retractor, managed to rip that fold, the splenocolic, devitalize the lower portion of the spleen. As you know, a portal hypertensive spleen is hard to gain control of. So ultimately mandating a splenectomy and devascularization rather than the shunt. And whenever Dr. Warren, on those rare occasions, had to take this out, take the spleen out, he would always comment, and Joe will appreciate this. He said, well, we had to take out the spleen, but at least we didn't injure the tail of the pancreas like the Bakey did and kill the Shaw. So that was an interesting time hearing about the Shah of Iran and all the problems that he was having, and DeBakey, a cardiac surgeon who hadn't done a splenectomy in years, having enough hubris to take out the Shah's spleen.
And also having, I was told by a person there, terrible vision.
Yeah.
So he couldn't see well.
Next slide.
Bad idea.
No good.
So the next part of the operation was to divide the retroperitoneal tissues between the lower border of the pancreas and the duodenum, fourth portion of the duodenum, known as the pancreatic groove, and isolate the splenic vein. Dr. Warren always would say during this part of the operation, now, John, don't forget to dissect right on the vein, because he always wanted you to divide the adventitia over the vein in order to take down the splenopancreatic perforators. And so he'd say, on the vein, John, on the vein. And dear God in heaven, please let me not have a heart attack.
Was that you or him?
Yeah, both of us. And then once the splenic vein was initially mobilized and surrounded close to the junction with the portal vein and the superior mesenteric vein, the coronary vein was always ligated at that point. And Again, we dissected well up underneath the head of the pancreas like Dr. Sarmiento does for his Whipple, and well down onto the superior mesenteric vein. Next slide. And then you progress out the splenic vein, mobilizing it and taking down all the perforators. And once the vein is fully mobilized, before you divide it, we would go and look for the left renal vein. Now, oftentimes in a very thin person, the left renal vein is easily identified through the retroperitoneal tissues. But in a lot of cases, it was not easily identified and oftentimes associated with a significant amount of blood loss, as Dr. Warren used a technique that he called dance of the suckers. And he and the first assistant would go back and forth through the retroperitoneum bluntly and try to expose the renal vein in that fashion. They were always careful to try and ligate retroperitoneal lymphatics in order to avoid chylous ascites. But if you look at the renal vein as it's exposed, there's a bit of tissue between the renal vein and the superior mesenteric vein. And that tissue is a lot of lymphatics. And we tried to dissect underneath that to fully expose the more proximal aspects of the renal vein. One time, Dr. Warren lifted a right angle clamp through that tissue and told the resident involved, and again, I believe it was Dr. Evans, now Craig, cut through this tissue so we can mobilize the vein further. Dr. Evans put his finger on that tissue and said, Dr. Warren, I feel a pulse. I think the superior mesenteric artery is in that tissue. And Dr. Warren, who had Dupuytren's contractures and not the best feeling in his hands, put his finger over that and he didn't feel a pulse. So he told Craig to go ahead and cut it because it was okay. And Dr. Evans put his finger on it again. Dr. Warren, there is a really big, strong pulse there. I don't think we should cut that. And Dr. Warren said, I know you're within 6 months of finishing your residency, but if you don't cut that, I'll make sure you're shoveling shit in Louisiana. So Dr. Evans, against his best judgment, went ahead and bovied through the tissue, and of course the SMA was in there. Dr. Warren reached down and pinched the tissue to control the bleeding, and then looked up at the circulating nurse and said, would somebody please call Robert Smith? And so they were able to repair the superior mesenteric artery. And I remembered that story, and it was always tremendously concerned about that particular maneuver. Dr. Warren was also very playful in a lot of his operations. One time I was doing a vagotomy and anerectomy with him, and we were trying to get around the esophagus in order to ligate the vagus nerves. And he had that perfect dissecting finger from his Dupuytren's up around the esophagus. And he went back and forth a while bluntly. And he said, okay, John, you put your finger up there and see what you feel. And so I put my hand up in there and reached behind the esophagus and rooted around a little bit. And the next thing I know, I'm pulling out the NG tube through a rent in the posterior esophagus, to which Dr. Warren looked at and he said, you didn't do that, I did. You tell everybody else that you did it. And at that point, he said, would somebody please call Kamal Mansour? Dr. Warren was never unwilling to call for help when needed. So after exposing the renal vein and elevating it to a point where a clamp could be put on it, we would divide the splenic vein. And Dr. Warren was always very careful to make sure that the splenic vein was short and straight to the left renal vein. He always commented, you want a short, straight shunt to maintain patency, not a curved, long shunt. And he noted when he visited other centers that were doing splenorenal shunts that one of the reasons that they had a higher bleeding rate is that they were not making short, straight shunts, but more long curved shunts which had a tendency to thrombose. The way they did the anastomosis, we did the anastomosis, was also unique. Rather than using a vascular suture such as Prolene, we would sew the back wall, posterior wall together with a 5-0 TEV deck on an RB1 needle in a running fashion, and then close the anterior wall with interrupted 5-0 silks. And when Dr. Warren was presenting a paper about the shunt, and he was asked, why did we use those particular sutures rather than Prolene? And he looked at the audience and said, because it works. And I think the main reason he liked to use it is because with his Dupuytren's contractures, he actually had a hard time tying Prolene, and it was easier to tie the TEV deck in the silk. Next slide. So as time progressed, we again realized that the alcoholic population of patients tended to lose portal perfusion due to the development of what was known as the pancreatic siphon, or pancreatic veins coming from the portal vein and entering into the splenic vein. And although the original shunt took down some of these veins, there was always still some of these veins left out near the tail of the pancreas. So ultimately, particularly in the alcoholic population, we developed what was known as the splenopancreatic disconnection in order to interrupt those intrapancreatic veins, also known as the pancreatic siphon. Next slide. There were other collateral pathways that also caused the distal splenorenal shunt to lose its selectivity. There was transcolonic varices. Again, we tried to address those with the splenocolic disconnection. And we took down the pancreatic siphon with the splenopancreatic disconnection. But there was always a third collateral pathway that we were not sure what to do with, and it was a transgastric connection. So again, we aggressively devascularized the lesser curvature of the stomach, the individual branches of the coronary or right gastric vein, in order to prevent that. However, a certain number of these patients, again, in the alcoholic population primarily, these veins would redevelop. And so there were several operations where we went back a year or two after the shunt, which was still patent in patients that were having progressive liver insufficiency, and ligate all those veins once again in all those three areas in an attempt to restore selectivity of the shunt and restore portal perfusion. And it was during this time that Dr. Warren hypothesized why port maintenance of portal perfusion was more than just a nutritive and oxygen flow issue with maintaining liver health. But he hypothesized that various hepatotrophic factors made by the pancreas, such as insulin, glucagon, and somatostatin, were partly able to go through the portal system and go to the liver and maintain liver health through hepatic trophic mechanisms. And so I can remember well being down in radiology with the interventional radiologist, going up through the shunt and sampling blood through all these various collaterals and sending them off for the various hepatotrophic factors. And then once we had divided all those collaterals, obtaining hormonal levels through the portal vein and the hepatic veins in order to document that indeed there was increased levels of hepatotrophic factors once these disconnections had been made. You can go to the next. So post-operative care in the distal splenorenal shunt was unique. The patients, probably the most unique thing is that they were given Decadron 40 milligrams IV Q4 hours for the first 48 hours and then sequentially decreased over the following week. And as you know, 40 milligrams of Decadron is equivalent to about 4 grams of solumedrol. So these were huge super pharmacological doses of steroids.
Patients were dancing in the room.
Yeah, it would be. They were always on a steroid high. And I think Dr. Warren enjoyed visiting them during that time the most because they were not feeling any pain. They had a lot of energy and very chatty.
What was the thought process behind that? Why? What
Well,
was he thinking?
I'll tell you what Dr. Warren used to say in talks. He said, "The dog data is clear."
Gotcha.
I never saw that dog, but it was clear. Usually by the third or fourth post-operative day, the patient crashed due to the weaning of the steroids. And I always noticed that Dr. Warren tended to be out of town on those specific days. And so that was one thing. We did stop doing that finally over time when we recognized that patients were developing significant sepsis from fungemia due to those high steroids. Other things that we did, the patients received D5W for fluids. Sodium was to be avoided at all costs in order to prevent the development of cirrhotic ascites. The patient was placed on a 30-gram fat, 2 grams sodium, 60-gram protein diet in order to prevent ascites, chylous ascites, and encephalopathy. They were not given lactulose as a prophylactic because of the risk of ileus, and they were not given neomycin. Rifaximin was not available then because one of Dr. Warren's close friends had been on neomycin for years and had developed significant deafness. So neomycin was a no-no. And on the first and second post-operative day, when the patient was in the unit, I would usually get a call from his secretary, Barbara Donor, and she said, "Dr. Warren says he's going to go to the ICU to see his post-shunt patients around 5 o'clock. So I would drop what I was doing, run to the ICU and examine the shunt patients. And if any of them had a heart rate greater than 100, then we employed the 10-10-10 rule. The patient was given 10 milligrams of propranolol IV, was given 10 milligrams of morphine sulfate IV, and was given 10 cc's per kg of ideal body weight of 5% albumin as a fluid bolus. And we repeated that as necessary until Dr. Warren made rounds in hopes that the heart rate would be less than 100 and preferably less than 80, because he felt like a heart rate of 100 was not acceptable in terms of ultimate liver perfusion. But he also realized that pain was a significant cause of the elevated heart rate, and he did not want his patients to experience pain. And this gets into a little side story. I owe my career at Emory in part due to an executive with Fuqua Industries, which was a major contributor to Emory. One of their executives was a white-collar alcoholic pancreatitic. And every so often, he would have an acute exacerbation of pain in his chronic alcoholic pancreatitis. And Dr. Warren would admit him for pain control. Sounds familiar, Jamie, doesn't it? So one night, the patient came in late, and the resident on call, a very nice lady by the name of Ann Kramer, went to see him to evaluate his abdominal exam and abdominal pain. And she realized after examining him that this was no more than his pancreatic pain. And Ann was a little tough. She told him that it was not her job to facilitate his alcoholism by giving him intravenous narcotics. And so she did not write for IV narcotics. I think she left him with some Tylenol and some Motrin. She apparently, when she left the room, the patient picked up the phone. They didn't have cell phones at that point, and opened his wallet and pulled out Dr. Warren's personal cell phone number and called Dr. Warren at 3 a.m. in the morning to ask about pain medication. So the next morning we were rounding, and back then there were the pink order sheets, and Dr. Milliken noticed in Dr. Warren's handwriting, timed at 3:30 in the morning, a morphine IV order for this patient. And Dr. Milliken immediately realized that Dr. Warren had gotten out of bed as the chairman of surgery and had come in and written the IV pain medication. I was on research at the time and did not have a specific third year PGY1 position. But needless to say, and sadly, in some ways, that was Dr. Kramer's last year of training with the Emory Department of Surgery. And I was the benefit of that. I took her place in the surgical residency program, at which time that was a pyramid program. So Dr. Warren's incessant feeling about adequate pain control. He also outlawed incision and drainage of perirectal abscesses in the emergency room. So it was not unusual to find INDs of rectal abscesses, even small ones, on the surgery board as time went on. So the shunt was looked at during the TIPS era. This was after Dr. Warren had passed away, and this study was carried on by Dr. Henderson and Milliken. And we looked at good function cirrhotics, Child's A and B. We had primary endpoints of rebleeding and encephalopathy, and secondary endpoints of death, ascites, and need for OLT. Bleeding control was a little better in the shunt population, but encephalopathy was no different, probably related to the fact that the TIPS is actually a small bore portacable shunt and therefore portasystemic shunt, and therefore does preserve some portal perfusion. Quality of life, cost effectiveness, and need for liver transplant was no different. The TIPS at that time had a very high intervention rate of 82%. That has since fallen to less than 30% with newer types of grafts, covered stents. Survival rate was in the 60% range for both, and only about 10% of patients ultimately went to liver transplant in these two groups. Alex Rosemary, a surgeon in University of South Florida, Tampa, did a meta-analysis of 4 shunt versus TIPS trials, again in good function, and found that the rebleeding rate and the reintervention rate and shunt malfunction rate was much higher in the TIPS in this meta-analysis, that the 2 and 5 year survival rates were higher in the selective shunt, and that once again, as we found at Emory, the number of patients that actually went to liver transplantation was very uncommon, despite death from progressive liver failure being 50% at 5 years. Next. So he concluded that selective shunting should be strongly considered over TIPS when surgical expertise is available in patients with good liver function. Dr. Rosemary was a proponent of the small bore H-graft shunt, which mimicked the TIPS in that it was, again, preserved some portal perfusion, and it was an easier shunt to perform than the splenorenal shunt. But he perfectly accepted the distal splenorenal shunt as an appropriate operation to do if the expertise was available. He felt that poor patient access and compliance made TIPS with its re-intervention rate less desirable, and that ultimately a TIPS as a, quote, bridge to transplant in the setting of variceal bleeding was often built but seldom crossed. And that pretty much remains the case today, where the surgeons have transplant surgeons and hepatologists now no longer do TIPS in poor functioning cirrhotics, except as a blood salvage procedure, and only unfortunately do them in the patient population, the Child's A and B plus cirrhotics, that would also be very well controlled with a distal splenorenal shunt. And so again, when considering waiting times and organ allocation concerns, liver transplant, while a primary therapy for liver failure, it was not necessarily a primary therapy in the patient with liver disease and variceal bleeding if the liver had good function, a low MEL score, because it was so good at controlling variceal bleeding. Next slide. So, Dr. Warren, as I said, over the years, became this larger than life person to me. He was always friendly. I could tell that he cared about my career as a surgeon and development as a person. My relationship, of course, changed with him over the years. I went from being a student and a resident and a fellow under his tutelage to a junior faculty member. And it was finally as a junior faculty member that I felt like I could call him a friend and a colleague. During his last week of life, it was my job to, he was still coming into the office. He was no longer doing surgery or clinical work, but he was still working hard to get the Department of Surgery ready for whoever would take the reins after it was gone. And one Wednesday morning I was called, and it was my job to stop what I was doing immediately and go down to the chairman's office and with a wheelchair, help him get in the wheelchair, connect the oxygen and roll him out to the little roundabout area in front of the hospital where his wife could pick him up and take him home. And on that particular Wednesday, as I was getting ready to roll him out of the office, he said, "John, turn the chair around. I want to look at my office." And so I did so, and he looked around and smiled. He said, "You know, I don't think I'm going to be coming back. This is probably the last time I was here." And I said, "Oh, Dr. Warren, you're just tired and you don't feel well today. You'll be back. You always are." He said, "No, I don't think so." He said, "I've accomplished what I set out to do." And he quoted the Bible. He said, "I have run my race." And with that, I took him out and he passed away that Saturday night on May the 5th. He was a great man. And I'm honored to talk about him.
Light behind you.
Don, we were honored to have you talk about him. I wonder if our Jeff would like to say a few things.
You have time?
Of course.
We don't close till midnight.
John has been talking and bringing all these great memories. And I know that the dean appreciated John as much as John appreciated Dean. Whenever John's name came in the faculty meeting, Dean was very, very positive about you and your future. You mentioned you were somebody who was giving him a heart attack in the OR. One time he was operating and he had chest pain. So they rushed him downstairs to have a coronary care. When he came back, I was afraid to ask. And I said, "How was it, Dean?" He said, "Finally, they found something normal in my body." Okay, John covered most of the thing, but I'll take you back to the pre-Atlanta years, which is 6 years in Miami, from January 66 until August 71, when we came to Atlanta. The best way to describe Dean is borrowing from a new book by David Brooks. People are two types: illuminators or diminishers. Definitely, Dean Warren was an illuminator by his definition. Three qualities, which were all, you agree with me, that Dean had: support you, see things in you that you didn't even know how to name them. And every time you have spent time with him, you get out with a self-appreciation and a better version of yourself. And these three things were obvious there. And the obvious to me, the first time I met him, in Miami after a long flight from Egypt. The secretary said, "Oh, this is Saturday." Of course, Saturday in Egypt is the beginning of the week. But the place was very quiet, and she said, "Let me take you." He's in the OR lounge. Dressed, necktie, sat down, found some residents in the lounge, and someone was a few years older than, some years older than them, talking about football and laughing, drinking coffee, and I'm sitting like the Sphinx. And then he turned and said, "Is someone helping you?" I said, we came here to meet Dr. Dean Warren. He said, "I am Dean Warren." I almost jumped off my no gray hair. He was almost not yet 40, the chairman. And all these residents are laughing and joking with him like this, sitting on chairs while he, it didn't take long. He said, "Let's go to my office." Started talking about admiration of ancient Egyptian history. And then he said, "Tell me about your experience with portocaval shunts in schistosoma patients." I told him it works very well. Stop bleeding. But these are poor peasants. They have to be healthy to earn a living. So the liver gradually went down, and they end up dying. He said, remember his words, "You to me, and I will work on this problem." And that was the beginning. The thing that caught my attention that he said, "You and me." In Arabic, you always say me and you. So he told me, "You and me." I left the office as happy as I could be, almost elated. And then pressing forward, and geography was not around yet in its infancy. Miami radiology, like any place else, was plain films and barium studies. So he knew something about angiography, and he connected with study of hemodynamics of portal hypertension. And they jointly with the radiology department hired one of the few radiologists who were dedicated to angiography at that time. Emory, when we came to Emory, the first angio suite was being built. So this man taught me how to do visceral selective angiography, which I did for several years. But there were two remarkable days. The first day, coming to your very nice presentation, we're looking at a sphenoportogram. And he kept looking, put his finger on a big collateral. "Look at this." I said, "What's this?" I said, "A big collateral, there are many of them. Look where it's coming from, where it is going." And it was coming from the splenic vein to the left renal vein. We can think of a way to decompress the varices that you described very well and maintaining portal blood flow. So that's the day to remember. The second day, he predicted that cirrhotics, as the vascular resistance goes up in the cirrhotic liver, portal blood flow cannot go through. He said one day the portal vein will become an outflow vessel. A year or so after that, I was studying a patient. I didn't believe myself. We inject the liver wedge, all the contrast came back, portal vein to the coronary vein to the esophagus. I jumped, took the pictures, but by that time he was the vice president of Emory, of Miami University, for medical affairs. Ran to his office and showed him the films. Guess what he said? He said, good films out there, good work. I thought you would jump off his bed and said, I told you so. He was not that kind of a person. He always gave you credit. And that's Dean as a researcher, such snapshots. Now, on a lighter note, Dean as he was an athletic by nature. He was very good. So in Miami, every weekend, we used to play tennis, Dwayne Hudson, and squash. So one day we were playing squash for the first time in my life, and the last. I swung the racket, hit him in the face. Guess who fainted on the court? Coming back almost finally to what you said, Dean, you have a person whose mind works at the speed of light. His hands work, let's say, speed of sound. That gave him the OR is not an advantage. So he never was afraid of bleeding, as you said. And you learn from him that every bleeding, regardless, eventually will stop. And at the graduation party of the residents, one resident flashed a slide that was in Miami, I believe. He said, if you walk in the OR and you hear the sound of more than one sucker, you know who's the surgeon. To the point that the last thing that as a department, we had group season tickets for ice hockey when it was here. And each one will go six games. So I happened, the first time ever I see ice hockey, and to my luck, Dean Warren was next to me in the box. A big fight happened. And there was blood all over the faces, uniforms, on the ice. So my reaction is, this is such a violent game. He turned around and said, Atef, that's what we pay our money for. He's a great guy. I cannot tell you how much he supported me when I gave him my resignation because my stay away from my position, like a scholarship, expired or was about to expire, and they tell me you either come back or. So I wrote my letter of resignation, gave it, went in person to give it to him. Guess what he did? Put it in the drawer. He said, he had a house in Naples. I'm going for 2 weeks. I'll not look at it. But you have time to think. If you're worried about the visa, he was very close friend of the president, President King. He has all the connections, he will get you the permanent visa. And once you get that, I'll have a position for you in the faculty. Think about it. And that was the turning point in my whole life. He was a great guy, and you did him a great service with your presentation. Tom,
Sir,
you overlapped with him for how many years?
I came in '87, he died in '89, I think. I didn't know him terribly well, but I would see him in the operating room and I would always ask him how he was doing. I was always somewhat amused by his comments. He said, "For a dying man, I'm doing okay." And I didn't quite know what to say about that. When he died, I'd gotten to know his secretary and she said, "Want you to come by the office and pick out some books of Dr. Warren. He would want you to have a couple of books." So I have a couple of books up here from his library. So great man. You did justice to him, John.
Thank you, Tom. Any Louis L'Amour books?
No, don't have any of those. I'm not too interested in that, actually. Any questions from everybody?
Well,
Yep.
can you hear me, Tom?
Yes, sir.
Just want to add a couple of things. I think we've done a magnificent job of a tribute to Dr. Warren, and certainly deserved. John mentioned that he quoted the Bible occasionally, and I've heard him several times in the operating room quote a passage from Galatians when things are getting a little tough. He said, "Be not weary in well-doing, for we will succeed if we faint not." And that was good advice. But when I learned to do the distal renal shunt from Dr. Warren over the next several years, I think I did about 50 between Emory and the VA. And I didn't have a mortality, which was an improvement over total shunting for sure. But also related to something John said, and you mentioned, Dean was still a Marine right up till the last. We were at a retirement party for Bill McGarity at a hotel in Buckhead, and my wife Flo was sitting next to Dr. Warren, and I was sitting on my wife's right side. And McGarity was across the table, and Flo said to Dr. Warren, "Dr. McGarity is going to retire and move to his farm. What are you going to do when you retire?" And Dr. Warren said, "Flo, you got it wrong. McGarity is retiring. I'm dying." And that made it sort of hard to carry the conversation much farther than that.
Dr. McKinnon, did you have anything you wanted?
Can I say something? This is Priscilla Strom. Hi, Bill McKinnon.
Hey, Priscilla.
How are
Good
you?
to see you.
I
I'm
know.
great.
And Dr. Smith and Dr. Salam. I love all these old names. It's so fun. Yeah, so I'm much older than John Galloway. So, but I remember I did my residency at Emory and my plan was to go overseas. At that point, I was hoping to go to India, but ended up in Bangladesh. And the reason I went into surgery is because I didn't know what kind of place I was going to be working in. I thought that would give you the best overall experience. If you were in a small hospital, you were the only doctor, or you were in a bigger hospital. So that's why I was a surgeon. And as a chief, you did 3 months either with Dr. Warren, or you did 3 months at Crawford Long with John Shellac, the Podna. And so Dr. Warren got to pick his chiefs, and he picked me, which was an honor. But I fussed to Dr. Bill Milliken, who was a good friend of mine, and as a junior attending. And I said, "Bill, I'm not going to be doing liver shunts in India." I said, anyway, so he went to Dr. Warren and told Dr. Warren that I was unhappy being on his service. So Dr. Warren called me and he says, "Priscilla, I hear you don't want to be on my service." And I said, "Well, Dr. Warren, it's not exactly that." And he said, "Crawford Long would be a better experience for you, wouldn't it?" And I said, "Yes, it would." And he said, "It's no problem. We'll switch you over." He was so gracious about it. And so I went to Crawford Long and learned how to do tonsillectomies and hysterectomies and other things from John Shellac, who was one of the old-timey general surgeons still around. And it was just awesome. I never forgot that about Dr. Warren. He was just so gracious that he wasn't offended. He just wanted me to achieve my career goals and did what he needed to do to get me there. And I just loved him for that.
Any other alumni online who want to say hello to the folks in the room that you recognize? And Dr. Pettit wanted to say
Yeah.
something else.
Yeah, I came here in 1985, so Dr. Warren, I interviewed with him. Rick Ricketts, I was only the second Emory pediatric surgeon. Rick Ricketts had come 5 years before me in 1980. And prior to that, according to Rick, Dr. Warren had not been a fan of pediatric surgery as a specialty, and you can maybe say something about that, John. Harlan Stone was at Grady and he ran the burn unit and pediatric surgery. And which is why for many years, even after Dr. Stone left, the burn unit and pediatric surgery were like joined together. The resident who on burns was the same resident on ped surgery. They ran both services. And according to Dr. Ricketts, the reason Dr. Warren had to change of heart was because apparently one of his grandchildren was born with an anomaly, and I can't remember whether it was a diaphragmatic hernia. Maybe somebody in the room can remember, but it was a serious congenital anomaly. And he realized that Emory did not have a pediatric surgeon that could handle it. On Fallowfield, and it had to go to Gibbs Andrews or Zwerin. Dr. Zwerin did it, I think. And he was very unhappy that Emory didn't have, at that point, he realized that maybe pediatric surgery had something to offer. And that was why he recruited Dr. Ricketts in 1980, because he wanted Emory to have a pediatric surgeon and not have people have to go to the other side. So, yeah.
Well, having, how to say it, be politically correct. Having worked with Dean Warren in Miami, there was no pediatric surgery there. And I mentioned the name that you recognize, Mark Rowe.
I trained under Mark Rowe.
And I will characterize Mark because his office was next to mine. He's a great guy. He ended up being one of the, you count on one hand, people at his level. But he was not happy. He was not happy. I mean, he accomplished so much. He started the pediatric surgery service there. There was Variety Children's Hospital that was doing all the work. And he did a great job. I look at him, he should be happy. But you see him walk in Dean Warren's office. Come out from the office dancing. You think there is a magician in that office. And eventually, he began to realize how great work he did. So when Dean came back here, it was political. Harlan Stone, his father-in-law is the G.D. Martin, whom he replaced. And it was difficult. So, but he hired Ricketts, which he did a fantastic job. He was not very much for Zierman, not as a pediatric surgeon, but he just didn't click. And he supported Rick, and Rick did a great job. I don't know,
Yes.
do you see him? Do you meet him?
Yeah, he's retired, of course.
Yeah,
By-
retired young.
Yeah, he retired. I think he was just coming up on 65. And yeah, he retired and he's living up in his house on the lake.
Yeah,
South
that's where he
Carolina,
moved
yeah.
to.
He and Sandy.
Dean's daughter that he was talking about, she had 17 operations. She was in the ICU for months correct me, Bill, 5 months, something like that.
Yeah.
Long time. And I remember one time I was sitting in his office and he said, I don't know, is there an end point here? And he was wondering. She ended up living and actually she did very well in schools. She had some problems still, but that it was very tough for him and for Evelyn, his wife. Follow-up story on that scenarios. Many of us took care of the baby during the rotations. And I had just rotated off, everything seemed to be fine. So 2 days later, the guy who took my place gets a phone call from Dr. Warren. Says, what are you gonna do about Tiffany's bowel obstruction? First he'd heard about it. I mean, he couldn't get to the bedside fast enough, but it all settled down, but he was very sharp to get such a phone call. But Dr. Warren was okay. He was happy for the residents to take care of the baby. And, at Grady, pretty much the residents took care of everybody back in those days.
Yeah.
I was so happy to hear that she left the hospital.
Typically at concerts and things, the big act goes after the smaller acts, but somehow I have to follow Dr. Galloway, and I'm not sure why that is the case, but we're gonna do this thing. So I have a talk prepared. It's going to be very concise and to the point for everyone. So we've gone a little bit over time, but a volume of the Emory School of Medicine yearbook. And I was able to haggle with some folks on eBay to get them to offer it to me at an acceptable price. Give me 1 second here. Let me share the screen. And so what I want to present today, and not only have the book here for show and tell, but I also want to present a couple of folks that I highlighted out of that book. And a lot of names are very familiar. And it'll just be the kind of the quick hits here, and then we can pass the book around and we can go through the book. And also I just have a copy of the history of surgery at Emory written by Dr. J.D. Martin. That's when everyone to sign the back of the book. And, maybe someday when my heirs put my stuff on eBay, some surgery resident finds it and is able to appreciate all the names that are in the back of that book. So this is actually a picture from the first volume of the Emory yearbook. This is volume 1, issue 1 in 1911. And actually wasn't even Emory at that time. It was the Atlanta Medical College. And then this is Dr. Westmoreland and Dr. Elkin. Dr. McKinnon actually personally showed me Dr. Westmoreland's tombstone at Oakland Cemetery. And that was a fantastic experience. And so the first person I want to highlight is William Simpson Elkin, born 1858 and died 1944. And so just some tidbits. So born in Lancaster, Kentucky, graduated from, I want to say, Center College in 1879. Significant about Center College. Around the time of his graduation and in the years that followed, they had about 2 Supreme Court justices. They had 14 senators. They had 40 plus college representatives. And there's actually remarks by Woodrow Wilson that said, Woodrow Wilson being so closely affiliated with, was it Princeton, I believe, said that there's a little college in Kentucky that's graduated more powerful men than all of the Ivy. And so that was Center College. He graduated from the University of Pennsylvania in 1882, and then, of course, was a member of the Southern Surgical. Was affiliated with both the Southern Medical College, which merged with Atlanta Medical College. If you know anything about the early days of Emory medicine, it's exceptionally confusing. 2 competing medical schools. There's, they fused at one time and break apart, and then ultimately culminated with what we know today as the Emory School of Medicine. But this man was very integral in making sure that happened. And so he was a professor of clinical surgery at Grady, which at that time when he was when he was attending there, had 400 beds, and then became the dean of the Atlanta College of Physicians and Surgeons, which is another one of those iterations of the medical school. Significantly, he was one of the charter regents of the American College of Surgeons in 1913. I want to say he was the only one from Emory that was. And then was would lobby the Candler family to kind of assist with bringing Emory Medical School as we know it into fruition. Significantly enough, we just talked about this earlier. Warren Candler was president of Emory College back in the 1890s, and so the Candlers had a big role in donating to the school and making sure that the buildings were erected and things like that. And then the Elkin that we probably are more familiar with is Dr. Daniel Collier Elkin, who was the first chair of the official Emory Department of Surgery. And so that's the second person that's highlighted in this book. He's highlighted in this book as a sophomore medical student. And so not much about him, but just it has his name there, and I can show you all the page. But born 1893 and died 1958, like I said, was the nephew of the other Dr. Elkin. His parents were publishers of the local newspaper, and so he went to Yale to get a degree in English Lit, ended up coming to Emory Medical School and graduated with the class of 1920, finished Yale in 3 years. He did his residency under Harvey Cushing at the Brigham, and soon after was appointed to be chair of the Department of Surgery, and he also was surgeon-in-chief of Grady in the newly built Emory Hospital. So he wasn't that busy for those 9 years, I suspect. He was the first J.B. Whitehead Professor of Surgery, and then when the Second World War came about, he was Chief of Surgery and then elevated to Brigadier General, which is a 1-star general of the Ashford General in White Sulphur Springs, Virginia, which isn't far from home. The House staff knew him as Dr. Dan, and then significantly, he was a member of the Yale crew team. This picture is actually one of the pictures that's in the Library of Congress of the Yale crew team, and he's somewhere on this picture. I don't know where. Take your best bet. And then the last person I want to highlight here is Charles Edward Dowman. Some of you may recognize that Dowman last name for the other Charles Edward Dowman, who was president of Emory for a period of time. But Dr. Dowman was born in 1882 and died very young at 49 in 1931. Significantly, he was the first neurosurgery faculty at Emory. So he did college at Emory, went to Hopkins for medical school, where he was mentored by Harvey Cushing, Dr. Harvey Cushing. Went across the pond and was a clinical clerk at the National Hospital in Queens Square, where he served under neurosurgeon Sir Victor Horsley, who was notorious for bone wax as a hemostatic, and then the skin flap, among many other things. And then he went back to the Brigham in 1911, where he was a professor of pathology, and then came down to the University of Alabama, where when he was performing the autopsy, he must have cut his hand and had a really bad hand infection, which put him out of work for a couple months. And so during that time, he went back and trained with Dr. Harvey Cushing, who was now at the Brigham from 1913 to 1914, and he credited that time for making him into the surgeon that he soon became. He was chief of surgery of one of the mobile units during World War I, which of course was one of the bigger offenses during that time and helped bring about the end of the war. And of course, I'm sure he got a lot of experiences with GSWs to the brain, which he does talk about. So his clinical focus was repairing cranial defects and peripheral nerves. First chief of neurosurgery at Emory and in the South. He was a founder of the neurosurgical clinic at Scottish Rite Hospital. Established at the Steiner building that we all know well at Grady, he established a pathology library there, mainly to characterize these brain tumors. Had a classification system based on what Dr. Cushing had described. And then he was a founding member of the Society of Neurologic Surgeons. I believe that was in 1929. He unfortunately passed in 1931. And here's a paper, some of the many papers that he was able to publish during that time with some of the local faculty. And just really quickly, so this is the excerpt from the first volume of the yearbook that you guys are about to see, and this is just it being birthed into fruition. And then I like yearbooks. I've collected quite a few yearbooks on the people that I admire. I think of history in a way like we're all connected, like family, right? And especially in surgery, it's like their lineages, their bloodlines. And so, these people, though I, don't know them and have no relation to them, I feel like they have some sort of familial tie to me because I've trained in the place that they've helped build. And so the same way you would look at, your parents' yearbooks or your grandparents' yearbooks to see, what were they like during that time. I do the same thing for folks who I think are an inspiration or should be an inspiration to me. And you get these little tidbits that I think humanize these giants. And so one of those things is they talk about the first Uncle Elkin, as we'll call him. They said, "What a society bug, Elkin, our delectable dean, by whose ingenuity and plastic surgery every woman may be restored to her social station, regardless of her nature of cheap complaint." And so, that's kind of significant too, because he ended up being a professor of gynecology as well, back when general surgery was general surgery. So there was some overlap, but he did do a lot of gynecology in his practice. And then Goldsmith, W.S. Goldsmith, who wrote one of the memoriam for Dr. Elkin and was a well-known general surgeon at the time. They made fun of him and said, "Why not use catgut sutures, Goldsmith, alias Jokesmith, who sews everything from peritoneum to front lines with catgut?" And then lastly, and this one I really appreciated, this is from Dr. McRae, who's also featured in the book as faculty. "It is reported as authentic there's not a single book in his library from which the appendix has not been removed, with due ACE precautions." So I'd like to thank everybody for coming out. Thank you, Dr. Dodson, for hosting us.
Thank that lady right over there.
And, oh yeah, absolutely. We have to thank you for the fantastic food and the overflowing beers and all the things that came with it.
Garrison, how much was the book?
So it's a good story. It's a good story. So initially, they wanted $175 for the book. I offered $65 for the book because I said there's nobody that is interested in this book. There's no way. And so they said no. And so I check again. They increased the price of the book after I offered $65 for the book. So I waited 3 or 4 weeks. I actually texted the book to Dr. Sullivan. I was like, "Dr. Sullivan, this book's expensive. You want to buy it? Buy it for me." It's like, yeah. You can text it to me. Never responded to me. So then
I'm not surprised.
a couple weeks later, I see the book.
Best part.
Yeah, I see the book still there. So then I offer them a price lower than the initial price, and they sent me the book. They sent me the book. So I'm very grateful for the book. I'll pass it around. You can flip through some of the pages. Some of the things that I think, may catch folks' eye. So this was John Funk. He was maybe I'm saying that correct. It was an E at the end of Funk. But he was one of the pathology professors there, and they kind of wrote a memoriam for him. We're still alive, but they kind of wrote his biography there. And all the yearbooks, which is interesting. So a lot of them are digitized. This one I don't think is digitized, but a lot of them are digitized. You can see, like joyful biographies of these people. They kind of jokingly call them nicknames and talk about his quirks and things. There's a lot of different folks who they end up writing biographies from over the different volumes. But you can look at, so they have like old pictures of Grady Hospital and, the first buildings of Emory. And so I think they had switched classes. They had switched the first and second year classes to the Druid Hills campus from where it was there at Grady. And so they kind of mention that how, they feel a little more detached from the first and second years because of the switch. Then they highlight all the new buildings that have been erected with that good Candler money. And they have pictures of all of those things.
They got over that when they moved the hospital out there.
Yeah, well, I'm sure.
Who paid for it all?
Yeah, the Candler money. I'm sure.
James the Candler paid for the whole thing. The whole campus, all of Druid Hills, donated the land. I don't think we give him enough credit.
No, well.
He was the owner of Coca-Cola.
Coca-Cola.
Distribution, wasn't it the distribution?
Yeah.
Yeah.
Bottling.
They bottled it.
Yeah,
That was the deal.
Atlanta bottling rights, yeah.
They went to see Candler and, they wanted to get the rights to bottle it. But they were going to offer him sort of an equal distribution as well. And he said he wanted nothing to do with it, didn't think they'd be successful, and had signed over the bottling rights, and they went off, made a lot of money.
The soda jerk that first served it, sold his rights to the thing for
Yes.
$100 or something.
That was Pemberton, wasn't it?
No, Pemberton was the inventor.
Okay,
This was a guy named Venable, who was simply the soda jerk, but he bought into it, but then he let it go. Gave away a fortune.
Silly person.
I didn't know this history when I first
He's
came
on
here.
You can
So I was walking in Emory Hospital looking for a Pepsi. What?
Well, I remember being in Dr. Warren's office, interviewing with him. And he asked me if I wanted a Coke, and he took me over to his closet, which now Dr. Sweeney has made into sort of a little wet bar area. Full of boxes of Coke. I mean, straight up box and box and box of Coke. And I said,
Yep, I'm back.
"Oh,
So I know, Bo Allen, one of our alumni is online and he wanted to say hello to everyone. So we're just gonna spotlight him. Dr. Dodson, he wanted to show you something in his room.
Bo, will you come back?
Hey, how's everybody doing?
Good to
Dr.
see you.
Galloway, Salam, McKinley, you guys haven't aged a bit. The rest of you guys, I'm not gonna say much.
And he was like, Joe and Johnny, you look terrible.
You need a-
Well, I haven't
you
got to
need
see
a-
Johnny yet from she's behind the camera, but Dr. Dodson, you remember this thing? This is the,
Can't see what-
can you see that?
I'm coming up to
Thomas
see.
Dodson Intern of the Year Award, 2011, the inaugural Intern of the Year Award.
Wow. How nice.
That was a bad year.
I hope you guys are all doing great. I had a blast tonight. Listen to you guys. I was going to watch Masters of the Air, but this is much more informative and more historical, in my opinion.
Come see us, Bo.
I would love to.
On that note, we will be having 100-year surgery celebrations in June of 2025. More to come. Thanks so much to everyone who's joined online. Thank you, everybody.
Thank you.
And one thing I do want to say before we end.